Right. So okay. So am I audible to everyone? A very good morning to all of you. Yes, a very good morning to all of you. Am I audible to everyone? Yeah. Okay, good. So yes. So day before yesterday, like we were discussing about the hyperkalemia, right? Where the serum potassium levels, if it is like more than 5 milliequivalents per liter, we used to call it as hyperkalemia. Now, exactly the opposite disorder we will discuss now, that is your hypokalemia. So when do we call the hypokalemia? We use the word hypokalemia when the serum potassium levels are less than 3.5 milliequivalents per liter. And I was discussing one important point, that the potassium, it is mainly an intracellular ion. And let me tell you what percentage of potassium is intracellular and what percentage of potassium is extracellular. Just 1 minute. Yes. So let me tell you the distribution of the potassium. So if you see the distribution of the potassium, consider this is the cell. Almost 98% of potassium is present inside the cell, whereas only 2% of potassium is present outside the cell, that is extracellular. Okay, now see, this is what, like this 2% is nothing but your 3.5 to 5 milliequivalents per liter, right? 3.5 to 5 milliequivalents per liter. Now, what are the causes for your hypokalemia, and intracellular ion, how is it being maintained? Everything I will discuss now. So yes, this is another very important question to all of you. Can anyone tell me why potassium is an intracellular ion? Why it is not being an extracellular ion? I said you almost like 98% of the potassium, it is intracellular. Can anyone answer me why the potassium is intracellular ion? To maintain the resting membrane potential. So what is that which will maintain the resting membrane potential? But that is not the exact answer, Kartika. Let me tell you. See, why potassium is an intracellular ion is, that is because of the membrane channel, that is sodium potassium ATPase, right? So it is this sodium potassium ATPase which will maintain the intracellular potassium. That what this channel which is present in the cell membrane will do, this particular channel which is present in the cell membrane, it will send 3 sodiums out and 2 potassiums in to the cell. So it is because of the presence of this particular channel or this particular ion complex, that is the reason why majority of the potassium is intracellular, right? I hope everyone has understood now. See, for each and every event whichever occurs in our body, we have a mechanism. All of you know that potassium is an intracellular ion, but you should have one small question: why potassium is an intracellular ion? Why sodium is extracellular ion? Why sodium is extracellular? What this particular channel or ion complex will do, which is present in the cell membrane, it will send, right? It will send 3 sodiums out, right? It will send 3 sodiums out. And that is the reason why your sodium is an extracellular ion. And it will send 2 potassiums in. That is the reason why potassium is an intracellular ion. Okay, so the conceptual understanding in general medicine is very, very important. And for this conceptual understanding of general medicine, your basic sciences are very, very important. Mainly the first year subjects, anatomy, physiology, biochemistry. These are very, very important subjects for understanding the concepts of medicine. And medicine, particularly if you want to have a very thorough concept, 4 subjects are very, very important. What are those 4 subjects? Physiology, pharmacology, pathology, and to a certain extent microbiology. These 4 subjects are very, very important in order to have a very strong concepts in the general medicine. If you are little weak in these 4 subjects, let me tell you, your base for your general medicine is not at all strong. Okay, you have to improve the concepts of these 4 basic subjects in order to have the whole in the general medicine. Okay, right. Having said this, now you need to know that, yes, if you see the total body potassium in a healthy adult, milliequivalents per liter, everyone is aware. I did not ask you even. Everyone is aware that the value is 3.5 to 5 milliequivalents per liter. Right, 3.5 to 5 milliequivalents per liter. Now, but what is the quantity of potassium in the milliequivalents per kg? This is very important. Okay, so the normal value is around 50 milliequivalents per kg in an 70 kg adult. That means in a 70 kg person, how much will be the total potassium value? That will be around 3,500 per a 70 kg person. Right, per 70 kg person. Now, out of this 3,500, right, out of this 3,500, what did I tell you? What is the percentage of potassium which is present extracellular? What is the percentage of potassium which is present extracellular? Any one of you? Right, very good, Kumaran. So it is around 2% which is present extracellular. So 2% of 3,500, that means, you know how much it will be outside? That is 70 milliequivalents will be extracellular. Okay, now you people should not get confused. Sir, you said like extracellular is 3.5 to 5. Here the units are milliequivalents per liter. Whereas here the units are milliequivalents per kg. Right? I hope you are able to make out the differences now. Sir, why is that we need to know? I will tell you. Because in the treatment part, you have to adjust the dosage of your potassium chloride in the same way. I will teach you there. Okay, right. Now, you see this. So in a 70 kg person, 3,500 is the total potassium, out of which 2%, that is 70 milliequivalents, is present extracellular. The remaining all are intracellular. The remaining almost like how much? 3,430 will be intracellular. Okay. Now, followed by that, let me tell you that a balance of potassium is being maintained. In certain parts of the body, the potassium is reabsorbed. From certain parts of the body, the potassium is being lost. Can anyone answer this question? What is the major route of the potassium loss from the body? Can anyone answer this question? Right? I'm very happy that you people are showing a lot of interest in the 6 a.m. club, right? And for attending this particular session, you should have an a push from inside, which all of you are having. I appreciate that very much. What is the major route of the potassium loss from the body? The major route of the potassium loss from the body is through urine. Very good, Vishnu. Very good, Kartika. Yes, whoever said DCT, renal loss, urinary loss, all are correct. Okay. Now, what are the other losses? Okay. The potassium, it is being excreted via three main routes. One is through stool, one is through sweat, one is through the urine, right? You might have come across these clinical scenarios. A patient presenting with gastroenteritis, having hypokalemia. I'll tell you one important clinical scenario which we have come across, okay? We had one 28 years auto driver, right? And he had presented to the casualty with palpitations. Palpitations was the presentation. And when we connected to the cardiac monitor, arrhythmias were there, right? There was VT or VF which was going on. And blood pressure, when we have checked, it was hardly 70 by 40 millimeters of mercury. That means he was hemodynamically unstable. Then, like what we have done, we have, okay, what will you do to that patient? Cardiac monitor was showing VT, blood pressure was 70 by 40 millimeters of mercury. What will you do to that particular patient? Can anyone answer? Very good, Vishnu. So you have to do electrical cardioversion, right? You have to do electrical cardioversion. So hemodynamically unstable arrhythmias, please remember, you have to do electrical cardioversion or the DC cardioversion. This is very important. And that is what we have done to the patient. And we have stabilized the patient, right? We have stabilized the patient. And as a part of, right, as a part of the routine emergency department protocol, right, we have done the basic investigations. We have done the RBS, random blood glucose, and we have taken an ABG also, arterial blood gas analysis. We have taken a 12-lead ECG and 2D echo. 12-lead ECG, after electrical cardioversion, right, the individual has come to the sinus rhythm. But ABG was showing marked hypokalemia. Potassium was hardly around 1.9 milliequivalents per liter. Now we need to know what is the cause for hypokalemia. Then once the individual is stabilized, almost it took 2 to 3 hours for him to get stabilized. And we were taking the history, right? So I am an auto driver by occupation. I will be just roaming around the entire city to take the passengers and drop here and there. And in the recent past 2 days, I had very bad gastroenteritis, right? Almost, I was passing almost like 10 to 15 times stools. And I also had severe vomiting also. Why? Because, sir, I eat here and there, wherever I get the food, I eat. So there might be some food contamination, because of which I had very bad gastroenteritis. So through that very bad gastroenteritis, there was potassium loss. Hypokalemia was there. And that hypokalemia, was inducing the tachyarrhythmias in the individual. Whereas you take hyperkalemia. In hyperkalemia, what is the cause of death? Day before yesterday, we were discussing about hyperkalemia. Hyperkalemia, what is the cause of death? Yes. Hyperkalemia, what is the cause of death? Very good, Rajeshwari, and all of you. Very good. So it is diastolic arrest. Diastolic arrest is the cause of death in case of hyperkalemia. Whereas in hypokalemia, what is the cause of death? I will discuss. It is not systolic arrest. I will tell you what is the cause of death. Okay. So the potassium loss is through even the stools. And how much is the potassium loss through the stools? That is around 5 to 10 milliequivalents per day. How many milliequivalents per will be there in a 70 kg person? Almost like 3,500 milliequivalents per will be there. And within the sweat, the potassium loss will be 0 to 10 milliequivalents per day. Whereas the potassium loss in the urine is a major loss. And how much will be the loss? That will be around in a 40 to 120 milliequivalents per day. And it all depends upon the potassium intake, right? It all depends upon the potassium intake. So these are all the sites from which the potassium is being lost from our body. Now, followed by that, yes, answer this. What is the site of reabsorption of potassium in the nephron? Yes, who will be the first person to answer this question early in the morning? Very good, Vishnu. Vishnu is very, very active. Very good, Vishnu. So it is the proximal convoluted tubule. Proximal convoluted tubule is the site where there is reabsorption of the potassium, right? And you see, please tell me the next question, Vishnu. What is the site of secretion of potassium in the nephron? What is the site through which the potassium is secreted into the nephron? Very good, Rajeshwari. You are the first person to answer. That is distal convoluted tubule, and Parthiban has answered it, collecting ducts as well, right? So the site of reabsorption of potassium is proximal convoluted tubule. The site of secretion of potassium in the nephron is the distal convoluted tubule and as well as the collecting ducts, right? Now, having said this, you need to know, why does the hypokalemia occurs, right? Why does the hypokalemia occurs? And you take hyperkalemia. Day before yesterday, we were discussing hyperkalemia. What are the two important causes of hyperkalemia we have classified that into? What are the two important causes of hyperkalemia, which we have? Very good, Vishnu. One is your transcellular shift. One more. One is your transcellular shift, and the other one is renal impairment. Renal impairment, decreased excretion due to renal impairment. That was the causes for hyperkalemia. Whereas you take hypokalemia, even here you have almost the similar causes. One is your transcellular shift. Right, and as well as the second important cause will be increased potassium loss, right? That is potassium depletion. Right, that is potassium depletion. Now, let me discuss about this transcellular shift. Right, let me discuss about the transcellular shift. So, if you take this transcellular shift here, the potassium from extracellular compartment, it will enter into the intracellular compartment. That is what is your transcellular shift. Whereas in hyperkalemia, what was happening? It is the intracellular potassium was getting shifted to the extracellular compartment. Okay, right. And okay, please tell me what was the causes for transcellular shift causing hyperkalemia? We will shortly revise. Yes. What was the etiologies causing hyperkalemia secondary to transcellular shift? Quickly, because we have discussed day before yesterday and you people have revised that as well. Can anyone answer? Very good, Monisha. It is acidosis, right? Acidosis. That is the one of the very, very important cause we have discussed, right? And followed by that, very good, Vishnu. Even we have discussed about drugs and as well as massive blood transfusion. Drugs and massive blood transfusion. Okay, right. Now, that was about your hyperkalemia story. Now, let me discuss about the transcellular shift of potassium from outside to inside causing the hypokalemia. So, yes, the first important thing is, what are the drugs that will cause the transcellular shift? The drugs which will cause the transcellular shift is, number one, beta-2 agonist, very good, Shiba, and the other one is insulin. Right, the other one is insulin. Actually, we have discussed one important multiple choice question also in the treatment of hyperkalemia. See, in the treatment of hyperkalemia, what is the drug of choice? What is the drug of choice for hyperkalemia? That is your calcium gluconate. But what is the most potent drug, or what is the fastest acting drug which will reduce the potassium level in the body? Very good, Shiba, it is insulin, right? It is insulin, right? Now, so your beta-2 agonist and as well as the insulin, they will cause the transcellular shift. They will shift the potassium from extracellular compartment to the intracellular compartment. Next, followed by that, when you give beta-2 agonist along with diuretics, right, that is loop diuretics, the hypokalemia will be very severe. Right, the hypokalemia will be very severe when you are using diuretics along with beta-2 agonist. Now, so you know now the drugs which will cause the transcellular shift. So what did I tell you? The two important causes for hypokalemia. One is transcellular shift. The other one is increased potassium loss, that is potassium depletion. But apart from drugs, right, apart from drugs, we have some other conditions that will promote the transcellular shift. Now, what are those other conditions? Right? What are those other conditions that will promote the transcellular shift? See, acidosis was causing hyperkalemia, whereas alkalosis will cause hypokalemia. Right? Exactly reverse. Acidosis will cause hyperkalemia. Alkalosis will cause the transcellular shift causing the hypokalemia. So it is both. Either you take respiratory or metabolic alkalosis. Okay, and insulin already we have discussed. Next, the other thing is even your hypothermia will cause transient drop in serum potassium. Right, even your hypokalemia will cause the transient drop in the serum potassium. Okay, now followed by that, let me discuss. So transcellular shift causing hypokalemia we have discussed. What are all those? Number one is your drugs, beta-2 agonist and as well as insulin. Right, and when you are giving beta-2 agonist along with diuretics, the severity of hypokalemia is very high because diuretics will cause potassium depletion. Next, alkalosis will cause the transcellular shift, and the next important thing what we have discussed is hypothermia will also cause transcellular shift. Next, now the other etiologies which will cause hypokalemia is the potassium depletion. Now the potassium depletion, you know, I said you the potassium loss from the body is via kidney, right, or via the gastrointestinal tract. Right, it is via the kidney or the gastrointestinal tract. Now, how will you differentiate both of these? You have to measure the urinary potassium. Now, the same urinary potassium, if you remember, we have discussed even in hyperkalemia also. Please tell me, what will be the urinary potassium levels? We will revise. I'm trying to compare hyperkalemia etiologies with the hypokalemia etiologies. Okay, right. Please tell me, what will be the urinary potassium levels if the hyperkalemia is due to renal impairment? Very good, Vishnu. Excellent. So, in case of hyperkalemia, if the hyperkalemia is due to renal impairment, right, that is kidney impairment, the urinary potassium will be less than 30 milliequivalents. Now tell me, which etiologies you have urinary potassium more than 30 milliequivalents per liter? In which etiologies of hyperkalemia, urinary potassium is more than 30 milliequivalents per liter? That is your transcellular shift. That is your transcellular shift. Okay, right. Now we will come out of hyperkalemia, right? We will come out of hyperkalemia into hypokalemia now. So now in order to differentiate, right, in order to differentiate whether the hypokalemia is due to urinary loss of potassium or whether the hypokalemia is due to gastrointestinal tract loss of potassium, you have to test for the urinary potassium. See, for suppose, right, for suppose, If the urinary potassium loss is due to kidney loss, that means due to urinary loss, urinary potassium value will be more than 30 milliequivalents per liter, right? And if it is due to diarrhea, what will be the gastrointestinal cause for hypokalemia? That is due to diarrhea. So if it is due to diarrhea, the urinary potassium value will be less than 30 milliequivalents per liter, right? So that is the importance of urinary potassium. If the cause for hypokalemia is due to potassium depletion, if it is due to potassium loss, then in order to make out what is the cause for potassium depletion or potassium loss, you have to do urinary potassium levels. And there is also importance of urinary chloride also. I will discuss that, right? Importance of urinary chloride, I will discuss. Okay, next. Then, what is the leading cause of renal potassium loss? Can anyone answer this? What is the leading cause of the renal potassium loss? The leading cause of renal potassium loss is diuretic therapy. That is mainly loop diuretics. What is the mechanism of action of loop diuretics? Yes. What is the mechanism of action of the loop diuretics? What they will do? They will inhibit sodium, potassium, 2-chloride ion. So thereby your sodium and potassium absorption right? Sodium and potassium absorption does not occur. Right? Sodium and potassium absorption does not occur. So there will be potassium loss, resulting in what is called hypokalemia, right? Resulting in what is called hypokalemia. Okay. So that is about the leading cause of the renal potassium loss. Having said this, what are the other causes of the renal potassium loss? One is your diuretic therapy. The other causes include nasogastric drainage, number 2, alkalosis, number 3, magnesium depletion. Right, number 3, magnesium depletion. So these are the other causes of the renal potassium loss: nasogastric drainage, alkalosis, and then the magnesium depletion, that is hypomagnesemia. Now we will discuss why does this nasogastric drainage or why does this hypomagnesemia will cause renal potassium loss. We will discuss now. So first let me take up the hypomagnesemia. How does magnesium depletion cause the potassium loss? See, whenever there is hypomagnesemia, right, whenever there is hypomagnesemia, let me tell you, this will impair the potassium reabsorption. This is very, very important point. Many of the physicians, they miss this. I will tell you one clinical scenario which we have come across. She was almost like a 38-year female patient. She presented with palpitations and we could make out the cause. Actually, not only palpitations, her main complaint was cramps. She was having severe muscle cramps and profound weakness, right? Severe muscle cramps and weakness. That was the presentation. And when we have tested the electrolyte panel, we thought hypocalcemia, but contrary to that, we got hypokalemia was there. Then we have admitted the patient, then we have infused the potassium, and we have seen that the potassium has returned back to normal. and we have also given pot clot syrup, and then we have discharged the patient. But within 1 month, again she came back with severe muscle cramps. Again, we have tested the potassium. Potassium was low. We were not knowing what exactly was the cause, right? We have checked the urinary potassium levels. We have done multiple investigations, but what we have missed was magnesium. Because usually we don't test the magnesium in the first line workup. Upon the extended workup of the etiology of hypokalemia, we have tested magnesium. There was severe hypomagnesemia, right? Magnesium was almost like less than 1 milliequivalent per liter. Then we thought that it is hypomagnesemia which was causing hypokalemia. So we have given magnesium sulfate, and followed by that we also have given potassium. Okay, so whenever there is hypomagnesemia, please remember this will impair the potassium reabsorption from renal tubules, right? And later on, once we corrected the potassium, we have never seen again the patient coming back with hypokalemia, right? So making out diagnosis is very simple in general medicine. Everyone can make out the diagnosis. What is this patient suffering with? This patient is suffering with diabetic ketoacidosis. That you can tell by doing the urinary ketone bodies levels. But the importance of general medicine lies in making out what is the cause of that particular diagnosis. If you are able to pick up what is the cause of the disorder, then you are the best physician. That is very important, you have to know. Okay, because it is only when you know what is the cause, then you will treat the cause and the patient will not come back to you with the same disorder. If you are treating only the disorder, the patient will again come back to you with the same disorder because you did not treat the cause. That is very important. Gastroenteritis is there. Hypotension, severe hypotension is there, due to which there is weakness. You have given only IV fluids and sent the patient. Do you think that the patient gastroenteritis will reduce? No. You have to give the antibiotics also, appropriate antibiotic for the organism causing that gastroenteritis. Then only you are the ideal physician, right? So please remember, from the general medicine point of view, it is not the diagnosis which is important. It is making out what is the cause of that particular diagnosis is very, very important. Okay, right. Having said this, and this is where we face a lot of challenges. In general medicine, as such, even if you see in the hospitals also, it is only just consultation. We don't do any surgeries. But you know why the bill of the patient who is admitted under general medicine will shoot up? Because of multiple investigations, right? So in the recent days, everything has become the evidence-based medicine. You need to make out what is that is due to. That means you have multiple etiologies for a particular disease. And when you investigate all the etiologies, the bill of the patient in the hospital will shoot up steeply, rapidly, and wherein they'll start quarreling with us, right? But adequate patience is also very much important for us to explain why we are doing this particular investigation. See, majority of the times, the patient and doctor discrepancy. You know why patient and doctor discrepancy occurs majority of the times? I don't say it is completely the mistake of the patient, and at the same time, I don't say completely the doctor mistake. It is the point where the doctor should spend adequate time in explaining why we are doing this. What is happening to the patient? If you tell superficially, the attendants will not be very happy, right? You should have adequate patience to explain what is happening, why we are doing this investigation. That is the point when the patient and doctor relation builds up. Your rapport with the patient builds up, and this patient will tell to 10 other patients, he is the best doctor, right? So your outpatient, your inpatient will grow. Okay, so that is the next thing. You are still in the level of writing the entrance exams, but this is very important even during your practice. That patient-doctor rapport and relation is very, very important. You should mingle with the patient. You should go to the level of the patient in order to bring that particular rapport. That is very, very important in your practice as well, which you will definitely understand and know once you step into the practice of any of this. Either you take general medicine or surgery or orthopedics or gynecology, anything. Okay, we'll come back to hypokalemia. So how does magnesium depletion cause potassium loss? Whenever there is hypomagnesemia, that will impair the potassium reabsorption from the renal tubules. Now, even what did I tell you? Nasogastric reabsorption or nasogastric drainage. How does the nasogastric drainage cause the potassium loss? See, whenever you are doing the nasogastric drainage, right? Whenever you are doing the nasogastric drainage, that has low concentration of potassium, but the resulting loss of volume and H+ ion will promote the potassium loss in the urine. So basically, whenever you are taking out the nasogastric fluid, you are taking out the potassium. You are reducing the fluid volume, right? And you are also reducing the H+ ion, which is present in the nasogastric fluid, because it is the HCl, which, where is this HCl present? The HCl is present within your stomach fluid, gastrointestinal fluid. So whenever you are taking out the potassium, that will promote the potassium loss. Sir, regarding the potassium loss, you have said, or you have taught multiple etiologies, how to differentiate. Yes, this table is very, very important. This flow chart is very important. So if there is hypokalemia, first you rule out if there is any transcellular shift. That means, is there any alkalosis? Is the patient taking any beta-2 agonist? Is the patient taking any insulin? Is there any hypothermia? Rule out the transcellular shift. Then you check the urinary potassium. If the urinary potassium is less than 30 milliequivalents per liter, it is diarrhea. And if the urinary potassium is more than 30, it is urinary loss. Now again, in the urinary loss, what did I tell you? Either it would be because of hypomagnesemia, or it would be because of nasogastric tube drainage, or it could be due to alkalosis also. Now, if the urinary chloride levels, if it is more than 25, then it is due to diuretic and as well as the magnesium depletion. And if the urinary chloride level is less than 15, then it is due to nasogastric tube drainage and as well as the alkalosis. So it is your urinary chloride which will tell you what is the cause of the urinary loss of potassium. What is the cause of hypokalemia secondary to your urinary loss can be assessed by doing the urinary chloride. Okay, right. So Harini is asking a very important question, that is hypokalemic periodic paralysis, right? It is an ion channel defect, which I will discuss now. We have some multiple choice questions on that hypokalemic periodic paralysis, which is an ion channel defect. It is also a congenital disorder, right? You have the family history. Family history is very, very important in case of hypokalemic periodic paralysis. Okay. Anyways, I'll discuss that subsequently. Now, yeah, extrarenal potassium loss, I have already taught you, that is through your diarrhea, right? That is through your diarrhea. And if it is through your diarrhea, what will be your urinary potassium? Urinary potassium will be less than 30 milliequivalents, right? It is less than 30 milliequivalents. Which one? If it is secondary to your diarrhea, right? Next. Now, the other important etiology is which will cause the hypokalemia is renal tubular acidosis. Which type of renal tubular acidosis will cause hypokalemia? Which type of renal tubular acidosis will cause the hypokalemia? Any one of you, please? Very good. So it is your type 1 and as well as the type 2 renal tubular acidosis. 1 second. Yeah, so it is your type 1 and type 2. And which type of renal tubular acidosis will cause hyperkalemia? Very good, Vishnu. That is your type 4. Now, I hope I need not explain, but anyways, I'll just give you a quick recap. You take the type 1 renal tubular acidosis. Type 1 renal tubular acidosis, the pathology is at the level of the distal renal tubule, which is also called distal renal tubular acidosis. Whereas type 2 renal tubular acidosis, can anyone tell me what is another name of type 2 renal tubular acidosis? Yes, can anyone tell? Yes, so this will be your proximal renal tubular acidosis. But Priyadarshini, you have another name apart from proximal renal tubular acidosis. You have some other name for your type 2 apart from your proximal. Can anyone answer this, please? What is another name? No. What is another name for proximal renal tubular acidosis? What syndrome is that? Yes, who will be the first person? What syndrome is that? No. Yes, who is that? Parthiban, Sangeeta, Monisha. Very good. Excellent. That is your Fanconi's syndrome. What is Fanconi's anemia? Can anyone tell me what is Fanconi's anemia? What is Fanconi's anemia? Very good, Vishnu. Fanconi's anemia is aplastic anemia. Fanconi's syndrome is your type 2 renal tubular acidosis, right? So you should not get confused between these two, right? Now, then followed by that, there are certain congenital disorders which will cause the hypokalemia, right? And what are those disorders? The two important disorders. One is your Barter's, right? And the other one is your Gitelman's. So Bartter syndrome and as well as Gitelman syndrome, in both of them, you have this hypokalemia, right? You have this hypokalemia. So how will you differentiate these two then? How will you differentiate Barter's from Gitelman's? Very important thing is that in case of Barter's, the magnesium levels will be normal, right? You have normal magnesium levels. Whereas in Gitelman syndrome, you have hypomagnesemia, right? So these are the two important ways by which you can differentiate. One, in Barter's and Gitelman's, both you have hypokalemia, but in Barter's you have normal magnesium levels, whereas in Gitelman's you have hypomagnesemia. And the other method is by your urinary calcium excretion. Urinary calcium excretion. Yes, Shiba, I'm coming to that. So there is increased urinary excretion of calcium, right? There is increased urinary calcium excretion in Barter's, and there is decreased urinary calcium in case of Gitelman's, right? So the Barter's, it will mimic what it will mimic. It will mimic the efficacy of loop diuretics, right? It mimics the loop diuretics. Whereas Gitelman's, it will mimic the thiazide diuretics. So these are all the etiologies which will cause the hypokalemia, right? And yes, Harini was asking me about the hypokalemic periodic paralysis. Let me tell you, hypokalemic periodic paralysis, the individual will have very severe form of hypokalemia. Right, hypokalemic periodic paralysis, which is the channel defect. There will be extreme muscle weakness, and the presentation will be from the childhood itself. Right, the presentation will be from the childhood itself. And what will trigger this particular weakness? Strenuous exercise will trigger this particular, the extreme muscle weakness. Now, can anyone tell me what is this particular channel defect in case of the hypokalemic periodic paralysis? Yes. What is the channel defect in case of the hypokalemic periodic paralysis, right? So even though we are using the word, right, even though we are using the word, even though we are using the word, the hypokalemic periodic paralysis, the channel defect which is being present here is the sodium channel defect is being present in patients with the hypokalemic periodic paralysis, right? Next, having said this, now what will be, what will be the clinical manifestations in patients with hypokalemia? See, mainly when the serum potassium levels are less than 2.5 milliequivalents per liter, that is the point when the individual will have diffuse muscle weakness, right? Diffuse muscle weakness and development of cramps and as well as weakness. This will be the earliest manifestation. And because of your hypokalemia, gastrointestinal motility is also reduced. There will be ileus. And muscle, there will be flaccid paralysis. Right? There will be flaccid paralysis of all muscles. Now, the very important multiple choice question now. Right? And what is that important multiple choice question? Yes, please answer this. What is the cause of death in hypokalemia? What is the cause of death in hypokalemia? The cause of death in hyperkalemia was diastolic arrest. Then what is the cause of death in case of the hypokalemia? Cause of death in hypokalemia. Very, very important question. It is not arrhythmias. It is not arrhythmias. Not at all arrhythmias. Let me tell you, the cause of death in case of hypokalemia is respiratory failure. And can anyone tell me what type of respiratory failure does these individuals develop? These individuals, they develop type 2 respiratory failure. Why do they develop type 2 respiratory failure? Because whenever there is hypokalemia, there is respiratory muscle paralysis. And that will cause hypercapnia, right? There will be carbon dioxide. There will be carbon dioxide narcosis, right? There will be carbon dioxide narcosis, okay, right? So that is the cause of death. Whereas in hyperkalemia, it is diastolic arrest. Then how do you investigate this patient? Investigation is nothing but your serum potassium levels you have to test. So in the investigations, let me tell you what all you have to do. In the investigations, you have to check the serum potassium. You have to check the urinary potassium. You have to check the urinary chloride. See, when you do all these investigations, then these investigations are mainly to make out what is the cause of hypokalemia, right? And another very important thing that will be asked in your exam is about the ECG changes. What will be the earliest ECG changes in hypokalemia? What will be the earliest ECG change in hypokalemia? Yes. Earliest ECG change, flat T wave, okay. Any other, apart from the flat T wave, do you have any other wave that will appear? Yes. So the other abnormality you should be able to make out is the appearance of the U wave. Right? And T wave, it becomes flat or it becomes inverted. Right? T wave, it becomes flat or inverted. You take this U wave. I will go back to the basic ECG. Can anyone tell me U wave is due to? U wave is due to? Anyone? U wave is due to, right? So it is due to repolarization of Purkinje fibers and papillary muscles. Right, repolarization, prolonged repolarization of the papillary muscles and as well as the Purkinje fibers. Right, that is why you have this U wave. So what are all the other ECG changes in case of your hypokalemia? One is, so the earliest change, what you people said, that is flat T wave or inverted T wave, and then appearance of the U wave, and very, very important is prolonged QT interval. How much is a normal QT interval? How much is the normal QT interval? Any one of you? Normal QT interval is around 360 to 440 milliseconds. Prolonged QT interval means it will be more than 440 milliseconds. Now, why are you very much worried? Whenever there is prolonged QT interval, what this will progress to? Anyone? What will this progress to? Very good, Sangeeta. This will progress to Torsades de Pointes. Right? This will progress to Torsades de Pointes. And Torsades de Pointes is what? It is a polymorphic ventricular tachycardia. Right? And that is how the individual will develop arrhythmias. That is how the individual will develop arrhythmias. So this is another ECG change. Next, there will be also ST segment depression. Now, in hyperkalemia, what was the earliest ECG change? In hyperkalemia, what is the earliest ECG change? Right? That is tented tall T wave. What do you mean by sine wave pattern in hyperkalemia? What do you mean by the sine wave pattern in hyperkalemia? Day before yesterday, I have discussed this. Right, very good, Sangeeta. So there is no P wave and you have a broad QRST complex. No P wave and broad QRST complex. Okay, so that is what is your sine wave complex seen in hyperkalemia. So now you take in case of, I'll just summarize both of these so that it will be comfortable. Hyperkalemia, hypokalemia. So in hyperkalemia, you have tall T wave. Whereas in hypokalemia, you have flat T wave. In hyperkalemia, there is no U wave, but here you have the presence of U wave. And the other important thing, in hyperkalemia, you have wide QRS complex, which will develop, and subsequently, there is no P wave. Whereas in hypokalemia, you have long QT interval and you have ST segment depression, right? So these are some of the ECG changes which you should know between hyperkalemia and as well as the hypokalemia. Having said this, let me discuss about the treatment. Right, management of hypokalemia. Very simple. What you have to do is your supplementation of potassium chloride, right? And how much you have to supplement? First of all, you need to, and okay, in the management of hypokalemia, you also need to treat the cause. Right, you also need to treat the cause of that particular hypokalemia as well. Okay, and let me discuss the how to estimate the potassium deficit. About 10% of total potassium is lost for every 1 milliequivalent per liter decrease in serum potassium. Normal value is how much? 3.5 to 5 milliequivalents per liter. Okay. And if the value is like 2.5 milliequivalents per liter, that means 10% of your total potassium is lost for every 1 milliequivalent decrease in the serum potassium value. And in case of milliequivalent per kg, what did I teach you? How much is the normal value of potassium in the form of milliequivalent per kg? No. It is 50. Normal value is 50 milliequivalent per kg. Right? Now, accordingly, what did I tell you now? So, for a 70 kg adult with a normal total body potassium of 50 milliequivalent per kg, the estimated potassium deficit associated with progressive hypokalemia. So now you need to know, like for example, even mild hypokalemia, that is serum potassium is like 3 milliequivalents per liter. You know how much is the potassium loss per kg? It is around 175 milliequivalent per kg is being lost. Normal value is like 50. And whenever there is hypokalemia in the form of milliequivalent per liter, normal value is how much? 3.5. If this 3.5 has become 3, you know how much is the potassium deficit? The potassium deficit is almost like 175 milliequivalent per kg of the potassium deficit will be there, or the total body potassium which is being deficit is around 170, not per kg, I'm very sorry, I'm confusing you. So if the 3.5 has become 3 milliequivalent per liter, the total body potassium which is being lost is almost 175 milliequivalents. So now how will you replace, right? How is the replacement being done? Okay, yes, you see, this is the table which you need to know. So, yes, Harish, I'm explaining you this. That is why I have come to this table. Okay, now you see, if the serum potassium is 3, right, the potassium deficit is around 175 milliequivalents. Right, it is around 175 milliequivalents. So it is like 50 milliequivalents per kg it is taken it as 4 milliequivalents per liter, right? Roughly for calculation purpose. Actually, it is 3.5 to 5, but I have just taken it as 4 average value. Right now, if the serum potassium value is around 3, right? If the serum potassium value is around 3, then what is the potassium deficit? The potassium deficit, it will be better. Okay, the potassium deficit will be around 175 milliequivalents, total body potassium. That means how much of the potassium loss is there? That is 5%. Actually, please don't get confused. I have taught you one point here. What did I teach you? That, yes, this point is very important. About 10% of total potassium is lost for 1 milliequivalent per liter. So 3.5, if it has become 3 milliequivalents, how much percentage of potassium loss will be there? For 1 milliequivalent per liter, it is 10% potassium deficit. For 3 milliequivalent, it is 5%. Right? 5% of the potassium loss. Now, 5% of, yes, we will come back to this now. One minute. We'll try to extract how this particular value has come. Right. So now, for 3 milliequivalent per liter, how much is the percentage of potassium loss? It is like 5%. So 5% of 3,500 milliequivalents. right? 5% of 3,500 milliequivalents. Or, okay, so if you take the 70 kg person, what did I tell you? It is around 50 milliequivalents per kg. Okay, and for almost in a 70 kg person, what did we discuss? It is like 3,500 milliequivalents. 5% of your 3,500 is being lost. How much it becomes around? That will be 175. Am I right? Am I doing any mistake? It is, yes, Harish, did you understand now? It should be actually some mathematics is going wrong, but 5% of 3,500 will be 175. All of you, am I clear or am I confusing you? It should be 3,500, 5% which is being lost. No, even this does not come. Yeah, so it is around . It is 3,500 into 5%. Yeah. Yes, 35 into 5. That is around 175. Okay. So now this becomes 175. I think now I'm clear now. So what I want to tell you is when the serum potassium is 3 milliequivalents, it is 5%. And if the serum potassium is 2.5 milliequivalents, it is 10% of the total body potassium which is being lost. 10%, right? 10% of your 3,500. So that will be how much? 350. And if it is like 2, it is like 15%. If it is like 1.5 milliequivalents per liter, it is 20%. And if it is like 1 milliequivalent per liter, 25% of your serum potassium is being lost. Now, how will you, right? Now, how will you do the potassium replacement? The potassium replacement is being done by your potassium chloride, right? It is by your potassium chloride. And this potassium chloride, it is available as the formulations. No, we have intravenous formulations also, and as well as the oral formulations. Okay, so you know, like your potassium chloride, it is a hyperosmotic substance. When you give KCl directly through the intravenous route, the individual will develop phlebitis. So this particular KCl, you have to mix with the saline. And in the ampules, you know, the intravenous ampules, whatever you are giving, it is almost 1 to 2 milliequivalents per ml will be there, right? 1 to 2 milliequivalents per ml. That means if you take a 10 ml ampule, 10 ml ampule will contain 20 milliequivalents of potassium. And this 20 milliequivalents of potassium, right, it is combined with 100 ml of saline. And then it is infused. Okay, why? Because it is a hyperosmotic substance. It is a hyperosmotic substance. And the other formulation what we have apart from potassium chloride is potassium phosphate. right? So this is the other alternative formulation which is available to us, right? Okay, so once the individual becomes stabilized, you can give the oral formulation of potassium chloride. But when the individual is hemodynamically unstable, where the individual is unable to take oral formulation, that is the point when you have to give through the intravenous route, right? Now, you just see one question. Yeah, so this is an important thing you need to know. That is, if the potassium levels are in between 3 to 3.5, oral formulation should be given, that is pot chlor. And when the levels are less than 3, or when the individual is unable to take orally, then you need to give potassium chloride. Then you need to give potassium chloride. Okay, and for 1 milliequivalent per liter increase in potassium, almost 200 milliequivalents of potassium chloride should be given. For 1 milliequivalent per liter rise in blood, how much of your KCl that should be given? Almost 200 milliequivalents per KCl has to be given. And this has to be given through a slow intravenous route, right? Slow intravenous route. Okay, now you see here, for suppose patient potassium is 2.3, right? Patient potassium is 2.3 milliequivalents per liter. Now, how much intravenous potassium, how much intravenous KCl has to be given? What is your target? From 2.3, you have to reach 3, because once you reach 3, you can give the oral route. How much is the deficit? Deficit is like 0.7 milliequivalents. Deficit is 0.7 milliequivalents. So 0.7 you multiplied by 200, because for raising 1 milliequivalent, you require 200 milliequivalents. And you want only 0.7 milliequivalents. So 0.7 multiplied by 200, how much it will become? 140 milliequivalents. So how much of your potassium chloride you have to give in 24 hours? 140 milliequivalents of potassium chloride you have to give in 24 hours. Okay, so that is how you have to calculate the serum potassium values. I mean, the requirement of potassium. I will show you some questions in order to get familiarized. What is the potassium requirement? How to calculate the potassium requirement? I will show you some questions now. So we will do some MCQs. Yeah. All of the following ECG changes are seen in hypokalemia except. Right. So tall T wave, it is seen in case of hyperkalemia. Right. Tall T wave is seen in case of the hyperkalemia. Right. Next. Which of the following presents with hypokalemia and metabolic acidosis? Hypokalemia and metabolic acidosis. Very good, Vishnu. Excellent. That is your diarrhea. Whereas in case of vomiting, vomiting will lead to metabolic alkalosis. Right? And in nasogastric suction, it is same, metabolic alkalosis. Whereas in case of Conn syndrome, there is hyperaldosteronism. So there will be potassium loss and even H+ ion loss. This will also lead to metabolic alkalosis. Okay, so it is your diarrhea which will present as hypokalemia and metabolic acidosis. Hypokalemia causes death due to. Right, so very good, Vishnu. So that is due to respiratory insufficiency. That is due to respiratory insufficiency. Right, next. Then maximum concentration of potassium delivered via central vein. Very good, Rajeshwari. So it is your 20 millimoles per liter. maximum concentration of potassium delivered via central vein is 20 millimoles per liter. Please remember, this is a very, very important question. Next. In hypokalemia, all ECG changes are present except very good. So whoever has answered B, see, some of you have answered C actually. Now, what did I tell you in case of hypokalemia? There will be a prolonged QT interval. And this prolonged QT interval will progress to polymorphic ventricular tachycardia. In case of ventricular tachycardia, how will be the QRS complexes? How will be the QRS complexes in VT? Is it wide QRS complex or narrow QRS complex? No, Kumaran, it is wide QRS complex. Narrow complex tachycardias, they are your SVTs, supraventricular tachycardias. PSVT, paroxysmal supraventricular tachycardias. They are your narrow complex tachycardias. Whereas VT is a wide QRS complex tachycardia. Okay, so wide QRS complex will be there. Prolonged PR interval can be there. But normal ST segment will not be there. There will be ST segment depression. Right? There will be ST segment depression. Okay, next. This is what we were. Yeah, almost. Anyways, a patient on amphotericin B has weakness and cramps. Serum potassium is 2.3 milliequivalents per deciliter. Calculate the total parenteral potassium supplementation to be given for the next 24 hours. This is what we have discussed, right? Yes. So you want 2.3 to become 3. And how much increase you want? That is 0.7 increase you want. So 0.7. So for rising 1 milliequivalent per liter, how much of the potassium chloride you have to give in 24 hours? For rising 1. For rising, yes. So that is around 200. So if you want 0.7 to be increased, so how much it will be? 140 milliequivalents per liter. Okay. So this is how you have to calculate the potassium correction. This is a very important question. In the entire discussion of the today, this question is very, very important. How to do the potassium correction, right? What is the rate at which or how much potassium chloride you have to give in the next 24 hours? This question is very important. And another point which is very important in the today's discussion is this particular table. Right, where I got confused and I have confused you little, but later you were so clever and yeah, this table. Yes, this is another important table that you have to know. That is, I will send you the PDF right away. I'll send you the PDF right away. So this table you have to know, right? And before the class, I don't know how many of you know about this value. How many of you know this value? I don't know, but please remember now. Milliequivalent per liter, 3.5 to 5. Whereas milliequivalent per kg, normal value is 50 milliequivalent per kg. That is a normal value, right? So this is about your hypokalemia. Okay, right. I'll just send you the PDF right away. Just give me a moment. I'll just send you in the chat box itself now only. And by the way, how was the class? Were you able to follow or was there any problem? Please just give me a small feedback which will help me. Hypokalemia. Yes. Yeah. So I have sent you the, I'm sending you the PDF. It is just uploading. Yeah. So it has uploaded. So just you can download that PDF, which I have sent you in the chat box. By the way, I will also send to your coordinating persons, wherein they will just send the PDF in the group as well. Okay. So today is your hypokalemia, and day after tomorrow we have one more session. Yeah. So day after tomorrow we have, yes, day after tomorrow we have one more session. That is, we will discuss the disorders related to your magnesium, right? That is hypomagnesemia and as well as the hypermagnesemia. Okay. So with this, I'll wind up. And if there is any suggestions, please let me know, which will be helpful for the further sessions. If any further suggestions, please let me know. PDF I have already uploaded, Harini. I will send to your coordinating persons also. If any suggestions, please let me know, so that I will correct my in the same manner like what you want. Is there anything that you want to advise, or sir, in this way if you do it will be better, so I will go accordingly? Is there any suggestions? Okay. Any doubts in your hypokalemia or hyperkalemia? Do you have any doubts in your hypokalemia or hyperkalemia? Right. So then we will wind up this particular session and see you again day after tomorrow. Right. Thank you very much. Have a good day.